Be the lecture on blood pressure regulation, and just a couple of things to remember: that the flow of blood through any part of our body in any given amount of time is our cardiac output, and our cardiac output is also equal to the amount of blood that we have in our circulatory system. And so we need to be able to control that flow, and blood will only flow when it's moving from areas of high pressure to low pressure. So in order to get the blood from the heart through the tissues and all the way back to the heart, we need to be able to maintain that pressure gradient so that blood will always flow. Blood pressure is the force per unit area exerted on the wall of a vessel, measured in millimeters of mercury. So as blood pushes against the wall, it exerts a force. As you probably know, systemic arterial pressure will be greatest in the large arteries near the heart, because the heart is what generates the pressure to cause flow to happen. And like I said, in order to keep blood flowing, we need to have differences in blood pressure. One of the things that helps us to create differences in pressure is resistance, or peripheral resistance. And this is the opposition of flow. It can also be a measure of the amount of friction, and like I said, we call it peripheral resistance. So there are several factors that determine peripheral resistance. One of these is blood viscosity, which is the thickness of the blood, and what that'll do is create an internal resistance to flow. You can think of blood in various viscosities as being anywhere between water or Kool-Aid consistency all the way up to honey or maple syrup consistency. And so as it becomes thicker, then that viscosity increases, the resistance increases, and the blood pressure increases. The second factor that causes resistance in a vessel is the total blood vessel length. So the longer the vessel length, the greater the resistance. Now in this particular case, we don't mean, somebody that has one really long vessel like Shaquille O'Neal, and it reaches from his abdominal aorta all the way down to his big toe. No, it can be short vessels as well, but as they branch, that adds to the total blood vessel length, and that will also increase the resistance. So as a blood vessel branches and becomes longer, total surface area that it can cover, then or cross-sectional area that it can cover, then again, the greater the resistance. Now, we notice this effect most dramatically when we increase our body mass. And typically, it's easier to increase our body mass by gaining adipose tissue than it is by gaining muscle mass. But either way, increasing our body mass will require miles of small vessels to serve it. And this is often why we see obesity. No, we see obesity in obese people. Why we see hypertension in obese individuals is because they have so much more peripheral resistance due to the amount of vasculature that it takes to go to all their body mass, tissue, cells. And the one that is the most significant in our control of peripheral resistance is blood vessel diameter. So when the fluid is close to the wall, it's slowed by friction, and the blood in the center flows freely. So as you increase the diameter, then you have more blood flowing freely through the center, and you have less blood coming in contact with the wall, and therefore resistance would go down as diameter increases, or as diameter decreases, then resistance would increase. And so resistance and diameter have an inverse relationship, and diameter and fluid flow, on the other hand, have a direct relationship. And you can see this is part of Poiseuille's law that you've read about in your textbook, that resistance is equal to 1 over the fourth power to the radius of a blood vessel. So you can see that resistance is very, very low as radius is very, very large. It doesn't take much to change resistance because it's an exponential effect. As you would expect, and as we said, that systemic blood pressure is greatest near the heart, so this will start the blood flow, and then pressure results when flow is opposed by resistance. So if we take a look at this chart, it shows the peripheral resistance, or the blood pressure changes as you go from the aorta down into the vena cava. As you can see near the heart, that the pressure is pulsatile, which means that the pressure down here, the diastolic pressure, is the pressure exerted just by blood being in the vessel itself. But then as blood is pumped out into the vessel during systole, ventricular systole, then you get that surge of blood that comes out. And that surge is going to be less evident as we get farther away from the heart. By the time we get out to the arterioles, we really can't feel a pulse anymore. Now, keep in mind that blood pressure still exists from the arterial to the venule end of the capillary bed, or else blood would pool out in the capillaries and never be able to return back to the heart. But you'll notice blood pressure is essentially zero when we get back into the vena cava, because blood is just pouring back into the heart. There's no contractile pushing force other than just pouring back into the heart, into the right atrium. Now, you'll notice there's a line in between the systolic and diastolic pressure called mean pressure or mean arterial pressure. So this really is, when we take away the effects of this pulsatile pressure, what is the constant pressure driving blood through the arterial system and then out towards the capillaries. And so this is mean arterial pressure, which is essentially the blood pressure driving the blood away from the heart. Okay, arterial blood pressure, when we're looking at the elastic arteries that are close to the heart, they're going to be rather compliant or distensible so that they can accommodate the surge of blood that's coming in from the heart. The blood volume forced into the arteries, like we said, at any time it's pulsatile because of the surges that come from the heart. And you've probably had your blood pressure taken before or done someone's blood pressure, and we know that we should have a systolic pressure around 120 millimeters of mercury and a diastolic pressure of about 70 to 80 millimeters of mercury, and then the pulse pressure is the difference between the two. And when we take our pulse pressure and we divide it by 3 and we add it to what our diastolic pressure is, then we know what is our mean arterial pressure. And that, again, is the pressure that is actually propelling the blood to the tissues throughout the cardiac cycle. If we calculate a systolic and diastolic pressure of 120 over 80, then we'll get a mean arterial pressure of 93. And this will decline, as it says, as we increase the distance from the heart. And mean arterial pressure also decreases due to the friction between the wall of the vessel and the blood. And so we saw in this previous picture how mean arterial pressure is dropping off as we get farther away from the heart. And as the diameter of the blood vessels gets smaller, then we're going to increase the resistance, and the pressure will also drop because of that. We've talked about this with capillary exchange and capillary dynamics. So when the blood pressure reaches the capillaries, it's about 35 millimeters of mercury. That's going to be the hydrostatic pressure. And then because of increasing resistance as it moves through the capillary bed, the pressure is going to drop to about 17 by the time the blood leaves the capillary. We want to make sure that capillary pressure is relatively low because capillaries are fragile, and we want to be able to have some blood pressure, however, to force filtrate or nutrients out of the blood into the stitial space, but to prevent edema from happening. Venous blood pressure, pretty steady, changes very little, and like I said, no measurable blood pressure in the vena cava. All right, so in the heart section, you've looked at venous return as how do we maintain cardiac output. So we'll just review this again. There are a couple of ways that blood is returned back to the heart, even though the pressure is very low. And so one of these is the respiratory pump. So changes in the ventral body cavity, pressure changes in the ventral body cavity when we breathe is going to milk the blood from the superior and inferior vena cava and back into the heart As we breathe in, then the volume increases and the pressure in our thoracic cavity decreases, and then conversely, when we exhale, then the volume decreases and the pressure rises. And so alternating between those two will milk the blood back to the heart with our respiratory pump, and our skeletal muscle pump will milk the blood in the veins of our extremities, because they're found typically between our skeletal muscles. And so as our skeletal muscles contract, then blood is pushed back toward the heart. And like we talked about valves in veins, those are present to prevent any backflow as this blood is being milked towards the heart. We also have sympathetic vasoconstriction. So the smooth muscle around the veins will constrict under sympathetic control, but because we have so little smooth muscle in a vein, the effect is not as great as we see in the arteries. This picture just shows how we can move blood around during times when we need it, say during exercise, and we need it in our muscles, and we need it in our heart, and we need it going to our lungs. And so I love this graphic. This shows what is our cardiac output at rest. There it is, the amount of blood that we have. And then you can see that we can triple it just by doing some strenuous exercise. And so you can see things stay the same. The brain always has the same amount of blood. I don't care what you're doing, it's always going to take its share of the blood all the time. Our heart will increase. Obviously, our skeletal muscle increases tenfold. Our skin will also increase because of our sweating. But we do not need to be making urine while we're strenuously exercising. That blood needs to stay out in our muscles. So we're going to shunt it away from our kidneys, and we're going to shunt it away from our abdominal organs, and then other places in our body. And so you can see where the blood goes. This picture just shows what happens to flow as we go through the vasculature. So flow will decrease to almost nothing when we get to the capillaries. The velocity anyway is very, very slow because of the great cross-sectional area that we have in the capillaries. It's almost 5 times what we have in the aorta. Actually, it's more than that, but it doesn't. 5,000 times more than that in the aorta. And the reason why is because twofold. We want to deliver blood to the tissues, and then we want it to be slow so that exchange can occur. And then as we decrease that cross-sectional area, then velocity will increase. All right, so what are the things that are going to regulate blood pressure? Well, as you looked before in your study guide, blood pressure or mean arterial pressure, either one, is cardiac output times peripheral resistance. So what are the main factors affecting cardiac output? That would be venous return and neural and hormonal control to affect heart rate. So venous return will affect stroke volume, and then neural and hormonal control would affect the heart rate. So the parasympathetic and the sympathetic are going to act again on the heart to change cardiac output and therefore change blood pressure. So the parasympathetic cardioinhibitory center, which will go and stimulate the heart through the vagus nerve, is in charge of resting heart rate. And during this time, our stroke volume will be controlled by end-diastolic volume, not really affected by a decrease in systolic volume, but primarily just how much blood returns back to the heart. But during stressful times, sympathetic stimulation, our heart rate increases, the stroke volume increases due to contractility, and that's because our ESV, or end systolic volume, decreases and cardiac output increases, mean arterial pressure increases. This is a really nice graph that just shows what causes all of these changes, and we're going to talk about every single one of these in just a few minutes. Okay, so what are the short-term neural controls of peripheral resistance? So the first thing that we can do is change the distribution of blood based on the demands of the tissues. So for an example is shunt the blood away from the GI tract during sympathetic stimulation and shunt it towards areas that require that. So the closing of those precapillary sphincters can affect blood pressure in those organs that need it. We can maintain mean arterial pressure by altering blood vessel diameter through vasoconstriction, vasodilation, and most of these neural controls are going to operate using reflex arcs with the baroreceptors. So the baroreceptors are going to be stretch receptors in the wall of the aorta and the common carotid artery, and they will send signals to the medulla to adjust what's going on peripherally to maintain blood pressure. Occasionally chemoreceptors will be affected or will cause an effect in higher brain centers too, and we'll be looking at more of those. So what controls blood vessel diameter? Well, in the medulla oblongata we have an area called the vasomotor center, which is going to send out sympathetic stimuli to the blood vessels to cause vasoconstriction to alpha adrenergic receptors in the norepinephrine that will be secreted by those sympathetic efferents. As I said before, the arterioles are almost always in a constant state or a moderate state of constriction to maintain our vasomotor tone, but of course at any time we can adjust that. This picture shows some things that will cause a change in peripheral resistance due to vasoconstriction or vasodilation. We have two mechanisms for this. We have an intrinsic mechanism, which is going to happen right at the level of the blood vessel itself, and that we won't have the higher brain centers or even the medulla involved. These factors will act on the smooth muscle itself and be very local. As you can see, distribute blood flow to individual organs and tissues as needed. Whereas on the other hand, the extrinsic mechanisms are going to involve things more systemically, so nervous stimuli, hormonal stimuli, to maintain mean arterial pressure. So this is to keep the pressure going throughout our whole body, where this is just is going to act locally to maintain flow in a particular organ or a particular area. We'll talk about all of these things as we go along. Here is how the baroreceptors work. So let's say, so they're negative feedback mechanisms. So let's say that you have a high blood pressure situation. So mean arterial pressure rises above the normal range. The baroreceptors in the carotid sinuses and the aortic arch would then be stimulated, which will send a signal. The afferents would send a signal both to the heart, to the cardioacceleratory center, cardioinhibitory center, and the vasomotor center. And the cardioinhibitory center then would be parasympathetic stimulation out to the SA node and the AV node to decrease heart rate. By inhibiting the cardioacceleratory center, again, we also decrease heart rate and decrease contractility of the heart, and so those things will decrease cardiac output. And then by inhibiting the vasomotor center, the smooth muscle and the vasculature will vasodilate, and that will cause a decrease in peripheral resistance. And so we've decreased cardiac output, we've decreased peripheral resistance, and therefore we've decreased the blood pressure. So now blood pressure returns back to a normal homeostatic range. But what if these act too much? Or you lay down, or you do something that then decreases your mean arterial pressure and the stimulus of the baroreceptors. So falls below normal range, baroreceptors are inhibited. Now, you know how when you're babysitting and you hear the kids in the backyard and yelling, screaming, and you know that they're fine because you can hear them. But as soon as it gets quiet, that's when you freak out. It's like, oh my goodness, what are they doing? And that's just like when there isn't as many inputs here from the baroreceptors to the cardiac centers in the brain. Then they think, okay, then we need to fire. And so the cardioacceleratory center will fire and increase increase heart rate through sympathetic stimulation and contractility. The cardioinhibitory center will be inhibited and the vasomotor center will be stimulated, and so we will get an increase in heart rate, an increase in contractility, which increases our cardiac output. We'll get vasoconstriction happening, which will cause an increase in peripheral resistance, and both cardiac output and peripheral resistance will return the blood pressure back to normal range. So that's what we do all day long, every minute, and not as much all day long, but as our blood pressure rapidly changes, so let's say you run across the street, or you're climbing a flight of stairs, or you're getting up out of your seat or something like that, then this is typically what's going to be happening, this short-term nervous control. So I just wrote out everything that I just said. So here's that, and there's that same. Oh, here's an important concept. So if this works so well at maintaining blood pressure when our blood pressure rises, how come we have chronic hypertension? Or why do we have high blood pressure all the time? Well, that's because our baroreceptors can become reprogrammed to a higher blood pressure level. So baroreceptors are ineffective in chronic blood pressure changes as they become reprogrammed during chronic hypertension to monitor pressure changes at a higher set point. So if they see that your blood pressure is characteristically at 150, 160, they're going to go, okay, I guess that's the way things are now, and we'll keep blood pressure at that level, and then anything higher than that, then we'll try to kick in. But of course, that's going to cause systemic problems as that high blood pressure continues. So what's interesting, though, if you have an individual that's on hypertension medications, maybe because they're obese, and then let's say they have gastric bypass surgery, and they can then get off their blood pressure medication and their body can monitor it on its own. So these baroreceptors can change what their set points are from time to time, depending on what's going on in your body. Chemoreceptors will also affect, but they'll have the same effect as the baroreceptors in using the glossopharyngeal and vagus nerves to pick up the input and send it to the brain, and then sympathetic stimulation or vagal stimulation going back out. So a vagovasal response. Vagal response. Oh my goodness, sorry about that. Where the vagus nerve picks up the input and carries it back out, is what I was trying to say. So when our chemoreceptors are stimulated, they'll be stimulated due to a drop in O2 or a drop in pH or a rise in carbon dioxide. And so because we want to get that blood flowing back to the lungs, we need to increase cardiac output and vasoconstriction and blood flow. And like it says, a rise in blood pressure that follows will then speed the return of blood to the heart and the lungs. And so that's why the chemoreceptors would be involved in maintaining blood pressure as well. Oxygen and hydrogen ions and carbon dioxide are going to act on the chemoreceptors, but we have other chemicals that will act either directly on smooth muscle or vasomotor control or the vasomotor center without involving the reflexes that the chemoreceptors use. So two of these chemical controls, short-term chemical controls, are the adrenal medulla hormones. So norepinephrine is vasoconstrictive. Epinephrine can increase cardiac output by increasing permeability to calcium so that cardiac muscle beats more strongly so that you can increase your cardiac output. That will then increase peripheral resistance. Increase blood pressure. A second one that is going to lower blood pressure is atrial natriuretic peptide. And so when there's congestion in the atria within the heart, then it will secrete ANP, which will go to the kidneys to decrease sodium reabsorption or increase sodium excretion. And because water follows salt, then as we get rid of sodium, we will get rid of water, and our blood volume and our pressure will decrease. And notice that ANP is antagonistic to a hormone called aldosterone that we'll talk a whole lot more about in a little bit, and also when we get into renal mechanisms. And then ANP can also cause vasodilation. Now, also working with the aldosterone to support that will be ADH, or antidiuretic hormone, or arginine vasopressin. Sometimes you'll see it vasopressin or ADH. It's the same hormone. And ADH will be released in response to dropping blood pressure, causes intense vasoconstriction during hemorrhage, and then will also go to the kidneys to increase water channels, aquaporins, in the distal convoluted tubule and the collecting duct, and reabsorb water from our urine, and thereby making our urine very, very concentrated. But that way we're not losing water, and our blood volume will go up. And anytime blood volume goes up, like cardiac output, then so will our blood pressure. Angiotensin II does a lot of things. We'll get into the long-term control, but just as a short-term mechanism, angiotensin II causes potent vasoconstriction. One of the most potent vasoconstrictors that we have within our body. And so as we get that acting on the smooth muscle at the blood vessels, doesn't have to go to the vasomotor center. It'll act directly on vascular smooth muscle and cause it to contract, thus causing vasoconstriction. Okay, now the endothelium itself can secrete some factors that will affect local blood pressure, like endothelin, cause a vasoconstrictor that allows calcium entry into smooth muscle in response to low blood pressure. And nitric oxide and ANP work very closely together in reducing blood pressure. So nitric oxide causes vasodilation, short-term effects, but very, very important in causing vasodilation and decreasing blood pressure. We have some inflammatory chemicals that will affect blood pressure. Histamine causes vasodilation, and sometimes if you're having you're in anaphylactic shock, you're having an allergic reaction to something, and so much histamine is released that you'll get systemic vasodilation that will drop your blood pressure, and your blood flow out to your tissues will be reduced, and you can die as a result of anaphylactic shock caused by histamine. Alcohol will also lower blood pressure by inhibiting ADH, and it depresses the vasomotor center, and so we get vasodilation, and then especially vasodilation in the skin. And because we've got so many capillaries going out to our skin, that if too much blood goes out to our skin, then not enough blood is going to make it back to our brain. Okay, so those were the short-term mechanisms. Now I'm just going to quickly get into the long-term mechanism, which is what that picture was with the kidneys. So long-term blood pressure regulation is due to the kidneys. And so how does it do it? It does it two ways. It has a direct mechanism and an indirect mechanism. So if we have an increase in our blood volume that causes an increase in our blood pressure, that will stimulate our kidneys to eliminate water. So higher pressure, more filtration, more urine production, which will reduce blood volume and blood pressure. So when we drink a whole bunch of water at one time, we don't have to worry too much about our blood pressure getting too high, because as soon as that blood, that absorbed water in our blood hits our kidneys, then that increased pressure will cause it to be lost. And then conversely, a drop in volume causes the kidneys to retain water because the pressure is less to cause adequate filtration, and water will remain within our blood volume or blood vessels, and the pressure will be maintained. So that's the direct mechanism. Rise in blood volume, kidneys filter faster, decreases time for reabsorption, and more fluid leaves as urine. And then conversely, a drop in blood volume reduces filtration, and we don't lose as much water. But the one that we're most concerned with is the renin-angiotensin-aldosterone system, or our indirect mechanism. So whenever blood pressure is low, and because we're primarily in a low blood pressure situation throughout the day, this is going to kick in. So this is our long-term 24/7 maintenance of our blood pressure. and not some of those short-term controls that I just showed you. So when blood is traveling to the kidneys, we have baroreceptors in the kidneys called juxtaglomerular cells. And what they will do is identify that it's a low blood pressure situation and will release a hormone called renin. And renin's job is to take an inactive hormone called angiotensinogen that's floating around in your body right now and convert it to angiotensin 1. Then as angiotensin 1 passes through the blood vessels in your lungs, there's a second enzyme called angiotensin converting enzyme that will change angiotensin 1 into angiotensin 2. And then it's angiotensin 2 that goes and does everything. So what does angiotensin 2 do? We've already said, first of all, it causes potent vasoconstriction. Then, so that can cause increased delivery to the kidneys, or if that's not going to be enough to maintain blood pressure, then the second thing is that angiotensin 2 can go to the adrenal cortex and stimulate the release of aldosterone, and then go to the posterior pituitary and stimulate the release of ADH. Both of these hormones will go to the kidneys, to distal convoluted tubule and collecting duct, and aldosterone will stimulate the retention of sodium, and ADH will stimulate the retention of water. And both of those will then increase fluid volume within the blood and increase blood pressure. Okay, so I've been at this for a long time, so now I'm going to hit shock really quickly, and then we'll be finished with that. So when we have chronic hypertension, what kinds of things are going to cause that? What we eat, our lifestyle, whether we are obese, our age, race, genes, stress, smoking, all of those things can contribute to chronic hypertension. How do we treat that? Typically with diuretics or beta blockers that decrease our sympathetic stimulation. Also, we can use calcium channel blockers or the ACE inhibitors, so the angiotensin converting enzyme inhibitors. All right, so let's skip through this because we already did this. Okay, and so we want to take a look at shock. So what is shock? Shock is when our blood vessels are inadequately filled to meet our tissue needs. So what are the various kinds of shock? Well, we can have hypovolemic shock, where we lose a lot of blood or fluid for whatever reason that you can see there. Will cause an increase in cardiac output, so our heart rate will go up. And so because we're losing fluid, our pulse cannot be very strong, but our body is doing what it can with the blood that it has to keep that blood moving, so increasing cardiac output and then increasing vasoconstriction. But if all of a sudden we see a sharp drop in blood pressure, then we know we have lost too much blood and the compensatory mechanisms just don't work anymore. And so we need to get fluid back into a person with a sharp drop in blood pressure because they just don't have enough blood anymore. And so here is all of that. And you can pause that to take a look at that or look at it in the PowerPoint that I've given you. All right, in vascular shock, we are not losing any blood volume. The blood volume is normal and constant, but we just are not circulating it where it should go. Typically because we have vasodilation everywhere in our body, and so we just don't have 5.25 liters is not enough blood to get to everywhere in our body. And when we try to send it to everywhere in our body, then our blood pressure is going to rapidly drop. So what are some things that can cause vascular shock? Well, anaphylaxis, and we'll look more about that in a minute. Septicemia, if we have failure of our sympathetic nervous system to maintain vasomotor tone, and even sunbathing can cause this because as we get really hot, then our blood vessels in our skin are going to vasodilate to help cool us off. And if you've ever got up real fast from laying out in the sun and you just feel like, I am going to pass out right this moment, or you've passed out right at that moment, that's why you did. All right, anaphylaxis is a loss of vasomotor tone due to an allergic reaction or some other release of histamine, which we've already said is a potent vasodilator. We can have cardiogenic shock, which is our heart is not functioning properly. We have pump failure because of too much damage in our heart. So we've had multiple heart attacks, and the blood is just not able to pump. We can have a left side failure, right side failure, or congestive heart failure. All of that can cause us to be in shock. And that's it. So I hope